Right, so I think it's 2 o'clock, and welcome to everybody, and particularly to our guest. I think we're expecting another guest as well, but thank you very much for being here as a member of the public. This is my first board, so I'm very keen that if I miss anything, please shout out and interrupt. I'm very keen also that we run to time. It's good practice for us all. I've not received any apologies from the board, although Miriam Heppel has just stepped out to do the bed state report, which is a vital executive role, and she'll be back in about 15 minutes. And Sandra's sent her apologies, of course, thank you. Sandra Caldwell, one of our non-executives. Declarations of interest, anything that isn't on the list that we have to add? No? So the minutes of the board held in public last time, which Sarah very kindly chaired. Any comments on the minutes? I'll go through them page by page. 1, 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11. Elaine?
Sorry,
Oliver.
Chair.
You're waving at me.
I just missed the right page, actually. There was just a minor amendment to the comment that I made at the top of page, I think it's 3 on the pages at the numbers at the bottom, which I've sent to Elaine, just striking something that doesn't quite make sense about machines without the context.
Thank you.
Just to clarify.
Helpful. We'll make sure they're amended. Any other comments on the minutes? No? We're happy with those? We can proceed. Thank you, Elaine. And then matters arising. Any matters arising from previous meeting that are not on the agenda today? No? And then the action log. Elaine, if you could just take us through that.
Yes, of course. So the first matter was 7.24 February, and that was the risk, the information governance risk being added as a strategic risk to the board assurance framework, and that has now been completed and it's included in the pack. The second item, which is 9.24 February, and that was the chair of the Safeguarding Board to be invited to the board to present the annual report for 23-24, and we've scheduled that for November this year. And then we were hoping to have Dr. Khan to present to this board on antimicrobial stewardship, but unfortunately he was unable to attend, so we've deferred that to the May meeting.
Okay, that's helpful. Thank you. I think it's a really important topic that the board should hear in public about, so that's helpful. I've not had any notifications of any other business apart from an issue that Teresa and I want to address in our reports that we'll bring to the board. Anything else that anyone wants to add to the agenda at this stage? No, thank you. Board assurance framework deep dive. I think this is you, Jackie.
It is. Thank you, Chair. So, as you know, as part of our regular review of the BAF, we do deep dives into each one of those risks. So, finance is its turn this month. So, I just want to point out one minor issue, which is that the large BAF spreadsheet, the ratings that are written down on that are not quite aligned to what's in my report. Okay. So that's it. I will update that and change that to make sure that they are properly aligned to one another. So I will assume that the report has been read, but there are just a few key points that I wanted to draw out of this, of the deep dive on finance, is that clearly we all are focused on finance an enormous amount as a board and as an organisation. I think we're still maturing as an organisation in terms of how we manage our finances, but I think we're well advanced along that route. And I think what I wanted to bring out really is that, to my mind, out of all of this, there are 3 key issues that I think we need to be minded of as a board. The one is clearly the clear and present risk to the current financial position in this year. And what I'd like to do is perhaps to put that over to our discussion of the management accounts later on in the agenda, and instead focus this part of the discussion on some of the other risks that sit in there. And I think for me, there are 2 major risks which are related to one another that are affecting our ability to provide ourselves with assurance around our financial sustainability. And they are the adequacy of our financial controls, which control our spending and make sure that we can assure ourselves that we're delivering value for money, and the adequacy of our funding. And I think that the key to sustainability and financial sustainability is that your funding and your activity are aligned with one another. That's how it's sustainable. And I think we have a gap in terms of between our expectations, our own expectations of what we want to deliver, and the expectations that are given to us and provided to us through the mandate, through the Ireland Plan, through the Sir Jonathan Michaels report, as well as our own expectations about the standard to which we want to provide services. And I think as long as there is a gap between those two things, sustainability will be very difficult for us. So I'd like us to explore that a little as a board in terms of how we might address that. In terms of the financial controls, it's related because a good robust system of financial controls would not address and fix that first risk that I've spoken about. If there's a mismatch between what you want and what you can afford, financial control won't on its own address that risk. So that's why I've had them as two separate ones. I think what I'd like to say on financial controls is that clearly as an organisation, we are continuing to mature in that regard. There are still gaps for us. Many of our key systems that we would use to exercise financial control are not quite where we would like them to be. So, for example, our accounting system is currently in the process of being re-looked at and re-procured by Treasury. Our purchasing is done on a manual purchase order book system rather than an electronic that allows us to track. So for an organisation of our size and our complexity, we have probably close to 800 or so individual budget holders, each of which has a different level of responsibility and financial delegation. Tracking that manually against a paper-based purchasing system is actually impossible in practice to exercise proper financial control. So it's absolutely necessary for us that we would have a proper electronic system that does that for us. Similarly, some of our systems that manage our control over our stock and over our assets are lacking. And again, we're working with Treasury to put those in place to help give us that assurance. Our spend on those areas is not huge. The biggest part of our spend in the organisation is on staffing. So again, we understand that there are discrepancies very often between the financial information and the information held in our OHR systems. So having that level of visibility and granularity and control and assurance is very difficult. It requires a lot of manual input in order to do that. We have had, when we began, we had very immature and very poorly developed systems of managing our rotas. So again, that's where most of our spend goes. That has improved significantly, but there's still further work to be done in terms of improving that and making sure that those systems actually integrate properly with our payroll. So one of the issues we have, which was brought about in a recent internal audit report, is that very often we have costs landing in parts of our organisation where they don't belong, and it's not immediately obvious how that's happened through the PIP system. So we spend an awful lot of time moving stuff around, and that makes it very difficult for budget holders to actually take ownership and control and manage what's in their budgets. What I would like to say is I think, in terms of the financial culture that exists within Manx Care, we've discussed this at previous boards, is that the level of knowledge that and ownership and accountability that our budget holders now take for their finances is in a completely different place to where it was a year ago, 2 years ago, 3 years ago. And I think that's the foundation on which we can now start to put in place actual systems and processes of control. Putting in procedures and controls on a system that doesn't even recognise its responsibilities in the financial sense is the wrong way around of doing it. So we've done an enormous amount of work around educating our budget holders, bringing our colleagues along in understanding the importance and the relevance of finance to their decision making, making sure that's fully integrated into everything that they do, and also working to make sure that we provide them with a level of information and reporting that gives them that visibility to exercise that control. We've made some recent developments in the finance team around introducing some additional resource to focus specifically on compliance, on controls, and on reporting, so that we can further develop that work. So I think we're on track, we're moving forward, and I think we're making huge strides forward in terms of our financial control. But we are limited by some of the systems that we need to operate. We're limited by the immaturity of our data. So in my nirvana, we will have finance data and activity data that actually link together. We are getting closer to that. I think bringing the finance team and the performance and the BI team under the one portfolio under mine helps with that. And in fact, from now on, the monthly finance meetings have morphed into finance and performance meetings. So managers will now not just sit with finance and then sit with performance. They will be looking at their performance and their finance in the same way at the same time. So it's starting to get those, even if our systems don't integrate, our people start to understand how those two things play into one another. So I shall leave it there. And happy to take any questions.
Thank you, Jackie. Really comprehensive summary of your paper. Before I open up, I'd like Nigel to comment as chair of FP&C, and then Kate, and then we'll go around and see other comments. So, Nigel.
Well, thank you, Wendy, and thanks, Jackie, for your presentation. So, colleagues around the board table know that I chair FP&C, the Finance and Performance Commissioning Committee, and we meet monthly and we discuss these matters very fully and very robustly. For members of the public that aren't seeing us today, also the finance team are sitting together in the same corner. So if one were to lob a hand grenade in our direction, you would take us both out at the same time. But I just want to bring a little bit of humour to what is clearly a very serious subject. I mean, we have been through a very public vote at the Tynwald Court to vote us an additional £30 million for the funding this year. So, you know, I'm sympathetic to and have heard locally the view that you've got enough money, stop whinging. I know it's not quite as simple as that, clearly, because we have been debating this subject for a long time now, and as long ago as a year ago, we were actually forecasting a £27 million overspend in this financial year. So there are no surprises here. Admittedly, it's still a very difficult subject to get your head around. But I think Jackie makes a number of very good points, because in the papers, Jackie has laid out the processes that we go through, from weekly budget holder meetings through to care group management meetings, performance and accountability reviews, the SIP programme, the finance. So there's a high degree of engagement around the subject of finance. And none of the people that I have met and none of the people that I question and challenge go to work to spend more money than they need to. So I think it's probably fair to assume that there are still efficiencies that we can eke out from the system. There are still things that we can do to improve things, but nobody is deliberately overspending and nobody is wasting money. I think I have a large feeling that we need to invest more to save more. Jackie touched on our purchasing system, the control of how we commission things. It needs to be electronic. Our patient records need to be electronic. We have, all of us, voiced frustrations around the progress of the transformative piece as opposed to what I call salami slicing. You know, the big shifts is what is going to make the difference to us and what is going to make the real forward movement. And I suspect we are spending quite a lot of our money patching up what we've got rather than transforming and moving forward. And I think if we were to look forward, and I know we have talked about this too, Chair, offline, if we are to move forward and model a little more, then I think the savings we can demonstrate going forward from transformation will be very real indeed. And I look forward to that. The other point, I think, is what we have to do is we have to continuously seek alignment of interests of our stakeholders, being our patients, our public, our government, Treasury and the department. And I don't think we're there yet. And I think we need to find that alignment so that there is a real understanding between the rhetoric, if you like, jobbing back to Sir Jonathan's report, and the reality of where we are now, because those recommendations that Jonathan made still stand today, but the funding doesn't. But I think we've got to stop whinging about the funding, because I don't think the funding is going to happen. There is pressure on finance across the piece of government. It's cold comfort, but we're not alone. And I think we have to live within our means, and maybe we have to say this is what we can deliver for this money, and that process has started. It started with a form of zero budgeting.
Yeah.
It's not quite zero budgeting, but we are actually saying this is the money, tell us what you can do, and more importantly, tell us what you can't do. So I think, you know, an overview, I'm very assured that the processes we go through at Finance and Performance are robust, challenging and supportive. But it's difficult when you're looking at, some would say an overspend, some would say an underfund of £30 million a year. But I think in this particular year, looking forward, we have to live within our financial budget, our financial envelope, to prove the efficacy of the Manx care model, which I certainly believe is the right one. But it's difficult to justify when you're looking purely at the bottom line, because it masks all the good things that are going on within the service. It masks the massive movement we've made in care, in quality, in safety, in behavioural values, in those things that we set out to be our vision at outset. So I'm very excited about that. But I think probably enough from me for the moment, and let other folk comment.
Thank you. Kate?
Thank you. So really just want to congratulate Jackie for the work that she's led around changing the culture of money and improving the financial literacy of the organisation. Having done the same thing in my organisation, it sometimes feels like you'll never get there. But what's clear is that all the right infrastructure is in place. I mean, clearly the point that you make around data is quite interesting, but having that shift in culture so that people are all on the same page about money is enormously difficult. So huge congratulations on that. And so my second point is in the context of that, which is you mentioned some of the paper-based systems, which probably keep you awake at night, particularly when one of them is procurement, because that's quite challenging. Is there notwithstanding Nigel's point around investment, is there any timeline to put anything in, or is it just simply that the money's too tight to be able to invest in that?
So in terms of the investment in the accounting system, so that's money that Treasury is investing. We expect the new system to be in place within about 18 months or so it's not that far away.
Great.
In advance of that, the finance team have done a piece of work to get more visibility and make it clearer where our financial delegations lie and who they're with, so that we've actually got a record of who they are. Yeah. So what the team are doing, they are preparing that information in anticipation of that and then going into the system.
Okay.
And then there's other areas that will then flow from the core accounting system to some of the other areas.
Wonderful, thank you.
Thank you. Paul?
Chairman, thank you. I just want to build on a couple of things that have been said, really, but just start by acknowledging to the board that Jackie's built a culture where there is a very strong ownership of this problem right up and down and across the organisation. And I think that's a really good place to be, because the challenges that we've got ahead of us are not insignificant. And I think that's quite a hard thing to pull off, and you've done that incredibly well. To the extent I think everyone in this room and everyone outside of this room working for Manx Care thinks about the financial implications of every decision that we're taking. Just to build a little bit on the point that Nigel made around alignment, when I think about this risk, we're really, in some respects, this risk is here and it's now. We are dealing with an unsustainable financial model for how we deliver care. And I think it underscores, in my mind, the importance of the work we are doing and continue to do to transform our service. It's absolutely vital that we're able to continue that in order to ensure, as far as we reasonably can, our finances are sustainable going forward. And I think, one of the things it reminds me of is there's two things we would helpfully need to understand how we align our position, and that is knowing what the demand for the service is going to be will help us to develop a long-term financial model. And I think it's safe to say in some parts of our business, demand will grow exponentially, and in others, it probably won't. And looking at how we organise ourselves around that demand profile might help us develop a long-term financial model for Manx Care that is more sustainable. And the second point is about expectations that people have. And I think that connects to people want value for money for the service they provide. So there's something in there around protecting a core of a service like ours, even if it may not be particularly profitable. It will be essential for maintaining a good quality standard of healthcare on the Isle of Man, which, if that's not there, would be a grave concern, I think, for members of the public. So I think those are helpful points that you remind me about when we think about alignment, Nigel.
Teresa.
Yeah, thank you. I'm always very conscious of being able to transparently describe why we've overspent. And I think we have an absolute responsibility as Manx Care to demonstrate we are driving out the efficiencies and productivities and making our service models as lean and efficient as we can and as safe as we can. And basically, essentially making the best use of the Manx pound. I am very conscious of the sort of headcount discussion that's going on across government, and Manx Care will almost certainly have contributed to an increase in overall headcount, but that doesn't always equate to increased expenditure. So myself and the executive are currently doing a piece of work to be able to transparently report on all posts, additional new posts which have gone into the organisation since the organisation started. We know they will be predominantly frontline clinical posts, which have essentially reduced our vacancy factor as an organisation. That have responded to increasing safe staffing levels. So a lot of those have gone into our wards and our emergency department, but also some of the new services that we have invested in as part of Sir Jonathan Michael's programme. So the HERE, See and Treat, and intermediate care. And I think we've got all of that well in hand, actually, and our internal governance gives us assurance on that. I think the bit of work that we must do quickly, and we're doing in response to the mandate, is ultimately in this financial position, what does Manx Care recommend is either stopped, slowed down or limited in order to manage within that budget. And I think that's where we perhaps need to do some more work to create those very clear risk-assessed plans, and in order to be able to have timely discussions outside of the organisation as to how we get those signed off and how we then implement that. I think that's an area where we were developing plans last year, but ultimately some of that wasn't able to be progressed in a timely way in order to respond to the level of overspend we were reporting. So I think that's where the board probably needs to focus moving forward as part of the operating plan.
Thank you. Any other comments from people? So I've just got a couple of things to say. I think as the newbie, I think the expectation of aligning our funding with the expectations from mandate, business we conduct, everything else is obviously key. But in order to do that, I think we have to be able to provide really robust information that isn't just real data that we have, but also modelling. So we need to get into the understanding what demand's going to look like, and we need to be a little bit braver about saying what the implications of that demand might be for both the service and the public. And I take your, what was it you said, no more whinging, Nigel, comment, which I think is probably something we should have on the wall somewhere. But I do think there's an element of, we have a very large sum of public money, and this year in particular we have to demonstrate really effective use of every bit of that. And I think what you're doing about the controls and to get clinicians to think about patient care and the quality of care in the context of finance is really impressive, because we all know that that is sometimes what slips when the conversation is happening. So And I do think the restructuring around the new clinical care groups gives people an opportunity both to learn and have a positive impact on that. So there's an enormous amount of work in progress. We need to make sure that as a board we're fully supportive of the changes in the business end, so what Treasury is doing to make the accounting easier. But I do think we also need to make better use of the data we already have to do those forward predictions. And coming on to the mandate, and my experience of mandates are that there's a maturing process on both sides, and that where we are this year, with the financial constraints that are common across the Western world in health and social care, we can have a different conversation around what the mandate might look like. And the advantage of the mandate is much of the aspiration within that is going to be effective in 2030 and 2060. So we are in a long-term planning part of that. How we reflect that on an annual financial budget is the key. So there's a lot to do, but I am persuaded by the path that we're taking. I do think that the Finance Performance and Commission Committee is robust, but I think we perhaps need to be slightly more proactive in saying what we would like to see in the future and how our financial planning can enable that.
So if I could just respond on that final point, I completely agree with you, and I'll reflect when I first arrived into Manx Care and what I found in terms of the tools available to me as a finance director to do all the things that we would like to do around financial control, around modelling, around planning, all of those things. They just didn't exist. And so I've had to use my, let's call it my judgment and intuition, an inordinate amount over these last 3 years in order to bridge, and I think we all have in our various areas, to bridge those gaps on the data. Our data is still not mature enough to do that planning in the way that we would want to do it. I think we need to really be clear on that. It's come a long way and we are using it, but it's not quite there yet to do what we would want it to do. I think, and what that does is a few things, is it hampers our ability to appropriately plan and allocate resources in the first instance. But the other thing it hampers our ability to do is to accurately and at a very granular, evidence-based way describe what actually this system costs or should cost to deliver. Because we're still having this question, is 347 million enough? There are some who say it's plenty. There are others who say it's nowhere near enough. But there isn't actually a way right now to answer that question definitively. And it's the same with the efficacy and the value for money, because ultimately the metric by which we are judged as an organisation around our financial efficacy is the bottom line. And when you judge it by that, we don't seem to be performing very well. However, when you look at some of the other proxies that we use as a board to assure ourselves that we are progressing in the right way, we look at things like, since we were established, inflation has been running at 20%. Our spend has increased by 19%. So increasing your spend more slowly than inflation, let's forget growth, investment or any of those things, just pure inflation, that's a massive efficiency in itself. That has been achieved without causing detriment to the services. That has been achieved alongside investment in services, improvement in services, transformation of services. So to do those things at the same time, I think gives us a proxy measure of our effectiveness and that value for money question. I think when you play in the fact that over these 3 years, £20 million in efficiency and cost savings will have been driven out of the system. That's an enormous, and I think these are the things that help us, I think, to give ourselves assurance that in the absence of hitting that bottom line figure, we are doing all the right things. But where I feel we have this gap remains, and I think I think it's for me the single biggest risk to Manx Care, is that if we're not able to articulate properly what this system should cost and then secure that funding, then it won't be a financial risk anymore. It will be a risk to us as an organisation in terms of our ability to deliver, because in order to meet the financial target, if that alignment is not there, then what you will have is that will be at the expense of service delivery potentially. And that's a whole other set of risks. And I know that primarily, and we talked about this, when it comes to our system, it's very uncomfortable and not a place that we would wish to be making some of these decisions around slowing down, restricting access, stopping. They have implications. They create harm. They create difficulties, and we need to be mindful of that. So I think we as a board and we as a system have some really tough conversations and work to do over the coming period to articulate it, because it's absolutely possible to deliver within the financial envelope that we have. There's no question in my mind about that. Where the question lies is what are the consequences operationally of doing that? And that's the piece of work we're doing right now. And I think once that's matured a little, we will have a much better ability to have some of those difficult conversations.
And in terms of board assurance, I assume we'll see the next phase of this in the business plan, which will come to the board in next month, I presume.
So yes, what we'll do as part of that budget setting process, I'll bring those priorities and what some of those decisions we might need to make are in terms of how we allocate our funding next year.
Okay, in the context of a business plan, I think. That will be, I think, the most helpful way of us seeing that, so that we see the totality of it. So thank you. Any other comments for Jackie before we move on? Thank you. So my report is very short this month because I'm on day 5. First thing I want to do is to formally and publicly thank Sarah for her sterling work, not only in stepping up in awful circumstances, but also in continuing her enthusiasm and her passion for Manx care through thick and thin. I've learnt a lot from her. I'm extremely grateful she's staying on, not just on the board, but as VC. I think we're lucky to have her. And I think Manx Care has not only survived, but thrived under her leadership. So thank you, Sarah.
Thank you.
From my perspective, what have I learnt over the last few months and weeks? I've learnt that there's a lot going on. I think we probably are now at the stage in our own growth that we can be a little bit more focused on what Manx Care wants to and needs to do. I recognise some of the financial constraints, but I see finance as an enabler, not a constraining. And I think perhaps some of the rhetoric around how we talk about money needs to be framed in that way of what will it allow us to do, as well as your anxieties, what it will stop us from doing. I do think that there are some issues around governance in the widest sense of its word, how we relate to the public, how we relate to the people we serve, how we relate to our colleagues in Tynwald, etc., as well as how we learn about what's going on in our own organisation. It's really complex, health and social care, but I do feel that if we can get this right, we will be looked at as an exemplar. And I came here because I think that is entirely possible. So we have agreed that we will be looking at a governance review, and Kate Lancaster will be scoping what that might look like for us, and we will bring, obviously, the terms of that to a public board in due course. I'm keen not to rush in. I want this to be something measured and thoughtful. It's building on lots of work that's already been done. We've had a board review that Sarah led. So there's an awful lot of stuff already there that we can build on. But it seems to me that as consolidating and the next step of our development, this is a useful way forward. And I'll obviously report further on that in upcoming meetings. So everyone's made me feel really welcome, both in Manx Care and externally. So thank you very much, and I'm really looking forward to my term of office here. We have one other issue that's come to light, partly because it's in the press today, and I'm afraid, forgive me, I don't know the name of the newspaper it's in.
It's the Examiner.
The Examiner. And it's an article called Medics Call for Reform. And it's from reporting on a medical society publication which was sent to our colleagues in the department and ministerial colleagues, not to Manx Care. There are some factual inaccuracies in that which Teresa is addressing. And there are some perhaps misunderstandings about the difference between Manx Care and a previous hospital or trust system, as we would call it in England. And that's fine, because actually this is good to have dialogue with our senior colleagues in a profession that is vital to the future of Manx Care is healthy. And that will be a healthy and robust dialogue. And Teresa and I have offered to meet to actually formally discuss this. But from my perspective, this is the time in which we want to hear this noise. We want to listen. We want to understand what people's anxieties are. And there's a lot of anxiety always in the medical profession about change. But the title of the newspaper report is Medics Call for Reform, and good on them, and we will be part of that reform. But we do need it on the basis of Manx Care being the organisation that reform will be delivered through. So we will bring that back to the board as a report back when we've met with our colleagues in the Medical Society. Teresa, have you anything to add to that?
No, I don't think so. I think you summed it up very well. Thank you.
And the formal response, I think, to them, obviously because the letter was to the department and government is going from government, but we'll chip in too. I think it seems reasonable, and you know we're all in it for the same reason, which is to improve the outcome for the public and patients.
The only thing I would add to what you've said, Chair, is that obviously Manx Care has been reflecting on what is the right structure for the organisation. You know, we inherited a structure 3 years ago. It's been on the agenda for the executive for a couple of years in terms of what is the best form and function for Manx Care moving forward. And so we had, you know, we've got a consultation which is just about to start on the new care group structures for the organisation, and we had specifically asked our medical leadership colleagues, led by Dr Hudson, to prepare a document to inform what that looks like. So how do we move to becoming a more clinically led, medically led organisation? So that work had started some months ago, last summer actually, has concluded, and that has informed how we move forward with our structural plans.
That's helpful. Well, I think, you know, obviously we need to share more and be out there more, and so we've made that commitment, and I'm sure that non-executive colleagues will support exec colleagues in going out there as we need. So thank you. So if there's no comments on what we've said, then we'll move on to your report, Teresa.
Thank you. The majority of the report I would take as read, and happy to take questions on. Just a couple of things to pull out. With regards to the independent Isle of Man COVID review, just to confirm, of the 31 recommendations which span all of government, there are no recommendations within the COVID review that are disputed by Manx Care, and therefore we will be progressing those implementation plans. A number of those recommendations do require some financial support, and that's where we're working with Cabinet Office in able to move that forward. I'm really pleased to report that the work at Hillside Dental Practice has now started. It's really great that we have now recruited to a number of those posts, and the clinical work of Hillside Dental Practice has commenced. We have kept all stakeholders informed of the progression of Summerhill View. So myself and David met with both staff, residents and carers in January to update them on the plans, and we have provided an update to residents, staff and carers regarding the work in the north of the island regarding the changes to Cummel Moor. The Independent Day Services Review has now reported back and has been monitored by the Quality, Safety and Engagement Committee. This piece of work will be a long piece of work. We recognise that this in totality is a sort of a 2 to 3 year project, where we will need to separate it into different phases, and each one of those phases we've given a very clear commitment to all the stakeholders that we will co-produce the solutions of that. So I just wanted to give an update and the assurance around that co-production of that. My final point is to just recognise that we have received now the final copy of the mandate for 24-25 for Manx Care. As I say, we don't get an opportunity to approve the mandate and accept it, but we have worked really, really closely with the Department of Health and Social Care to make sure that those 5 priorities are basically there is strong alignment to. We've had the opportunity to share those priorities more broadly. Myself and the Vice Chair met with the chairs of the voluntary and community sector this morning, and I met the chief executives of the voluntary and community sector last week. I see a real strong alignment between the mandate delivery and transformation, and what the organisation needs to try and achieve through the mandate delivery is to deliver against the requirements of the Care Quality Commission inspection and Ofsted, to deliver our CIP and to deliver our mandate objectives. So combining those 3 strong elements, aligning the transformation programme and mandate delivery. So there's some proposed governance changes in there. With some executive leadership of the priorities, requesting some NED sponsorship of those priorities as well, to give them a good profile in the organisation. And just to sort of see that work being taken forward. There's a schedule and a plan around the budget setting process. So by the time we come back to the board in April, what we will have is a draft response back for the board to consider our operating plan in response to the mandate, and all of that budget setting being aligned. Happy to take any questions on the report.
Any questions? Sarah.
Just to reiterate the very positive meeting that Teresa and I had this morning with our voluntary chair colleagues, I think there is a very strong will to work together to where we can to improve some of the outcomes for the population of the Isle of Man. And I guess kind of linked to that, Teresa, in your report you talk about the strategic partnerships. And I know as a board we've talked about visiting some of those partnerships, and I just would, kind of reiterate, I think, the desire that the board has to do that, and to congratulate you and Oliver on establishing those, because I think they're really important to the delivery of health in this particular instance for the people of the Isle of Man. So I think if we could, I know we talked about maybe a board-to-board with colleagues, or maybe more informal visits, or a mixture of the 2. I think that would be very welcome.
Thank you. Yeah, I mean, I think, we have, Oliver particularly has worked really hard developing with his team those partnerships. And of course, it is about getting those really good patient pathways and outcomes for our patients, but also it's the opportunity to link in with those expert centres. We've certainly had looked at opportunities for training, service improvement. We've recently had a visit from a colleague in Alder Hey who's helped us with some of our children's services and looking at areas where we can improve. So we absolutely see these as really, really important relationships through that strategic partnerships and those memorandums of understanding. And equally, the discussion this morning, Sarah, wasn't it, was sort of moving towards a more strategic partnership arrangement with some of our key voluntary community sector partners too, to enable us to really work more closely with them, get their input into our future service delivery models.
Yeah, no, thank you. It's a point really well made, Sarah. I think, strategic partnerships have to be nurtured, and we can't leave it all to Oliver. So I think we'll take it as read that we'll find a way of. I think we certainly should meet board to board in some form or another, and I'll chat to Oliver and colleagues about how we might make that work. And I'm really keen that, we heard at the last board the funding for a cardiac specialist nurse from a charity. There's a great big hole in the ground that Macmillan are digging for a new building out the front there. So I think it's really important that we maximise the value of the third sector and support it vocally and visibly with Manx Care. So thank you. Really important meeting. Any other comments on Teresa's report? No, thank you. Committee chairs reports. Tim, QSC, anything to raise?
Thank you. Nothing to add to the report, Stan. Thank you.
Nigel, anything that we're not covering in the follow-up item, Jackie's? Or?
I don't think there is, Chair, actually. Only to report that, not surprisingly, we're alert to the fact that the Department and Treasury are going to have a bit of a review, an external review of our finance governance
It's
structure.
really helpful. Do you want to just spell out what we've got? 2 potential reviews, haven't we?
We certainly have the first one, which is again not surprising given the results of this year, but I see this as actually a very positive move, because I think it will enable us to have a useful exchange of views, and it will enable us hopefully to seek better alignment with our stakeholders in the shape of the Department and Treasury. So this is an external review by I think an expert from the UK. I actually met him this morning and had a very helpful chat with him. I found him to be open and communicative, objective, very professional, and I think very interested in what we represent. And I think the views that he will provide over a period of time will be very helpful to us and the department.
Absolutely, thank you.
So pleased with that. At the committee meeting on the 29th of February, you have the papers. I think some usual culprits turned up, but the one that I would escalate, I think, is this frustration over shared services agreements. And I think we really need to focus this year on getting that communication and getting that dynamic right, because again, we're responsible without power, and I think that's a dangerous combination, as it is the other way. And I think we really need to focus on that, and certainly at FP&C we heard some difficulties around that.
Yes, and I think I picked up positive support for those clarifying conversations from our colleagues in the department and ministers yesterday.
Yeah,
so
absolutely.
I think this is it's a work in progress, isn't it? But
yes.
Shared services are always a bit of a challenge, but I think we've got specific issues that we can now formulate clearly and use them through Miriam perhaps as a lead on some of this, and Jackie around how we might make best use of shared services and do our bit to save them trying to do it.
And I think, Chair, if I may just come back on that, I think you've got good people working on both sides, but there are frustrations provided by the system and the way in which we are being required to work rather than what we're doing.
Yes, I would absolutely. Yeah, that's what I've learned in the last few days, so thank you. So we will no doubt come back to that formally when we have understood a little bit more about what our position is, and hopefully it'll be a joint position by then. So thank you. Anything else, Nigel? Any comments on anything, and anyone that was at the committees that wants to raise anything? No? Thank you. So we're on to the integrated performance report. So I think we're starting with you, Paul, aren't we?
Thank you, Chairman. I think I'd like to just say, in terms of the quality measures in the report for January, in what were very difficult testing circumstances, we've delivered a good result overall, I think, against a broad set of quality measures. If I can just summarise some for the board's benefit, continue to have strong progress on the exposure to the risk of never events. We're in our 31st consecutive month without a never event. I was here when the last one was here, and since then we've put an enormous amount of effort into theatre safety management and improved clinical practice, and it's paying dividends, and it's a testament to the frontline staff and the work they do that we get those results. Similarly, earlier in the year we identified a risk around Clostridium difficile infections, which, for those who don't know, is an infective diarrhoea. And we put in place a safety management plan to help us deal with those issues in the autumn, and this plan has delivered the improvements that we sought, and our exposure to Clostridium difficile infections now is well underneath what we would expect. But we have to be vigilant with this. There are what we call hypervirulent strains of Clostridium difficile circulating in the UK, and these are very difficult to treat. So we are keeping our dander up in that regard. We've restored our improvement trajectory for antimicrobial stewardship after a slight dip, and I know that we're all going to get a chance to see Dr. Khan and his team in a few months' time, but we delivered 90% compliance with the check, which is our best result yet against that particular improvement goal that we've got. We do have low exposure overall to alert organisms in infection prevention control, particularly MRSA, but I'm watching with concern the rise in E. coli infections, E. coli bacteremias, that we can be a hazard in acute care that we're working on. We continue to enjoy good performance from our advice and liaison service, and in, this month in particular, in January, we doubled our response rates to the friends and family test, which was quite encouraging because last month we discussed it, and I wonder if members of the public were listening to our conversations. But it's still the case, even though we've increased our response rates, that 90%, so 9 out of 10 people who use our services say their service was good or very good. Now, I know that's not perfect, but I think that's extremely good in the circumstances, and that's a consistent outturn that we get against those measures. The areas I am concerned about this month, going into the remainder of this year, is I've commissioned a deep dive into the rate of inpatient falls. They doubled in January, and I can't say for sure what exactly is behind it, so which is the reason why I want to do some more investigation. But I suspect there'll be a combination of factors playing out that are going to be linked to acuity and dependency, the number of occasions we were on Opal 4, and some of the challenges around staffing. But I'm going to take a report back to the Quality and Safety and Experience Committee when I'm able to, just to set out some assurances for Tim and other members of the board on what we're doing in relation to harmful falls. And in relation to E. coli infections, I'm going to extend our safety management plan for the IPC just to make sure we're picking up the things that we need to be focused on in relation to the prevention of E. coli bacteremias. And that will link to wound care, catheter care, and a number of other areas that we need to be focusing on a bit more directly. And Chair, I'll stop there if there are questions, or allow others to continue.
Okay, any questions or comments? Thank you. So I think it's Marina next.
Thank you, Chair. Just to comment about mortality, we continue to do very well. We achieved 98% for January. The target we're trying to hit is a threshold of 80%. So we've continued month after month to achieve very good results in our level 1 mortality reviews.
That's okay. Not anything else?
No.
Nope. I want to say. Any comments?
I'd just like to also add about the mortality reviews. I've just looking back at my papers from a year and a bit ago, and we were just nowhere near looking at deaths, and I just think the amount of progress that's been made during the last 6 months, the year has just been absolutely amazing. And so really commend Marina and the medical team for all their hard work on that, and I think it's just really important for us as a learning organisation to be able to understand. So thank you very much for that.
Thank you, Tim. David?
Thank you, Chair. Yes, performance remains pretty good across the piece in terms of all service areas. We're consistently reaching thresholds and targets in most of those areas. Exception of 2 areas. So one is the adult social work side, where we are still struggling to meet the 28-day timescale for completion of assessments generally. Part of the reason for that has been around learning disabilities, which we know are much more complex in nature. And more recently, very recently, we've got agreement now to move that target from 28 days to 6 weeks for learning disabilities. I think that's more realistic, and that's now included in the mandate. Okay. We've shifted that kind of threshold a little bit. It still poses a challenge for us in terms of capacity, but at least it gives us a fighting chance, I think, in terms of the LD side. And the second area where we've seen a dip in performance is around complex needs reviews held on time in terms of children and family services. That's dipped down from 85%, which is the target, of 34%. We do understand why that's the case. Some of that's down to capacity, but it's also around availability of family, other professionals, other agencies. So we understand that. We've done the analysis of that, and now it's about working towards improving that. And again, some of it is around capacity from the children's social work side. Other than that, performance is fairly static and fairly steady, I think.
Okay, thank you. Any comments from anyone about that? Nigel.
Chair, may I come back to Paul, if I may? Forgive me, I'm a bit late on this, but Paul, you talked about the Manx Care and Liaison Service, and apart from my absolute horror at the endless amounts of acronyms there are in this service, which I can never quite keep up with, MCALs, wonderful service, and I supported it hugely when it was first proposed, early days. There's a danger that when you're talking about good things like responding within 1 day or 90% friends and family tests, that we could be perceived as being self-congratulatory. And I think it's right to mark the fact where we're doing well, and it's absolutely right to give huge credit to the teams. But outside, we talked a little bit about as well perceptions, and perceptions are everything. Is there anything we can learn from the amount of calls we're getting through the Manx Care and Liaison Service, the helpline, if you like, as to areas where there are consistent issues? Yes. And what do we do with that data? And how do we turn those, if you like, concerns or complaints or connections into positives where we can get some really easy wins to improve our perception with the public? So as not to appear self-congratulatory, but to appear as if we're continually improving.
I think that's a very important question that you raise, actually. And yes, there is a lot we can learn. And as a board, there's a lot of information and intelligence we can get from the MCAL service and the feedback from the Friends and Family Test, and also from complaints. And for the minority of people that have problems with our service, it's very consistent what feedback they're telling us. And would it be okay if I just read out a couple of things that are of concern to service users? So, the big issue that people have is access to care, and the time it takes, and the amount of time people are spending on waiting lists. And that would probably be an equal share between diagnostics, like waiting for a diagnostic test or waiting for an appointment to see somebody or for treatment to begin. That's a big concern for people who are waiting, and that theme crops up quite a bit. There are specific issues that some people experience that concern their treatment, particularly if the standard of care as they perceived it was not what they would expect. Some people have issue with the way staff handled them, so they felt they were dealt with in an abrupt manner, or staff weren't particularly caring or courteous when they tried to raise their concern. In some cases, service users are dissatisfied with the quality of the service that they got. They felt the care wasn't to a high enough standard, and in some cases they feel that they need to seek redress through the proper channels. And then lastly, I think the other theme that stands out for me is information that we provide people to connect and enable them to be active participants in the care process. Sometimes that's lacking. I mean, it can be as benign and as simple as not knowing where to go. And in other cases, it can be quite complicated about what they need to do in order to comply with drug regimes, etc., and things like that. So there's an awful lot still to do to get that right. And even though it's a minority of people who have those experiences, it nonetheless serves as a reminder to us that we have to continue to drive improvements in the way care is organised and the way care is delivered, so that we can continuously improve that for people and minimise that risk.
Thank you. Really well made point, Nigel. I assume that this data is shared across the care groups, so that they can see where they sit in the scheme of things. I wonder if the board would welcome a deep dive into complaints, MCALs, and what our responses and what we're learning from it at some stage, and whether it is it put on our websites in the public domain? Can people see that? Because that is a driver for change in itself, and also whether people who are not in Nobles use MCALs, and if they don't, what's their option? So in primary community care and social work, how do we hear their voices? Those are the sort of things I think we'd welcome at a deep dive session on the board. Perhaps if we could think about...
If I might extend and see, would it be possible for the team to come and meet the board when they give that feedback to the board? Because I think that'd be...
They came quite a long time ago.
Yeah. Okay. Well, let's...
So it might be worth another...
Yeah. Let's plan a...
And you might benefit from that as well.
a session where we can hear. But I think what are the next steps in the development of this? What are we learning from it as a board? And how does it filter into our, everything from the mandate to the finances to the retention and recruitment of staff, well-being of staff. That sense of direction of this would be, I think, really helpful. So we'll talk to Elaine offline and work out when. Tim?
I think it's a really good point you make about what's available on our website, quote unquote, in terms of us having a website, which is our website, where we can publish that kind of information, because I think it really is, in terms of transparency, really, really helpful for members of the public to be able to see things like the numbers of complaints, which departments, how they were resolved, etc. And I don't think that is available at the moment on the Isle of Man government Manx care website. I think there's a lot there about.
Of course it goes that way, doesn't it?
I think there's a lot there about how to make a complaint, etc. But I think there's not any nice infographics and everything, which makes it easy to see what what's happened to that information.
Thank you. Oliver first, then Teresa can tell us how we're going to do this.
I think it's a really important point that Nigel's made. I think complaints where something's gone wrong, I think they're a really valuable resource for an organisation. And I think when people are complaining, I think, one, they want things to be fixed for themselves, but I think people want to be heard. And I think many people who complain, they would like to know that their complaint is taken seriously, which I think MCALS does, and to know that they're contributing to making the organisation better, to actually that their complaint is received positively, and we should be saying thank you for complaining, thank you for highlighting this to us, and thank you for pointing us in the direction to make things better.
Absolutely, no, they're gold dust in terms of what they tell you. Teresa?
Yeah, so an improved public-facing web page for Manx Care, away from the standard government linked through web page, is in our development plan. As you recall, we focused particularly on our internal intranet because that became our repository for policies, how we updated our staff, but it is part of the plan for the next financial year to have that externally facing website.
Excellent. That's great. Thank you. Really, really good to hear. Anything else on the integrated performance report from anyone? No?
Oliver, just to do his.
Oliver, sorry. I'm so sorry. I didn't forget you. I just missed your name off my list, so apologies. Oliver, of course.
I'll just give you some highlights from an operational performance point of view. So first one being elective waiting lists. R&R2 has now completed. The last R&R recovery and restoration list was on Sunday, and that is the programme now complete. So just in terms of summarising the number of procedures that we've managed to deliver through R&R2, it has been 1,794 cataract procedures, 582 orthopaedic inpatient procedures, so that's hips and knees, 208 orthopaedic day case procedures, 213 inpatient general surgery procedures, so they're majority of hernias, lap choles, etc., and 330 day case general surgery procedures. So a pretty huge dent out of our waiting list, which I'm very pleased to say that in those services that have had R&R completed some time ago, so particularly cataracts, we are managing to maintain that waiting list, so we're not seeing it go down and then go back up again, and that's thanks to the particularly the productivity that we've managed to achieve through adopting the synaptic methodology for running cataract lists, so primarily increasing from 4 on a session to 9 on a session. In terms of next stages, so we're really glad to have now submitted what we hope is the final version of the next phase of recovery and restoration, which is restoration and recovery phase 3, which predominantly looks at us recovering our outpatient waiting list, which is just as a summary, includes 10,800 first outpatient appointments, so those are patients who are waiting to be seen by a specialist for the first time, and then just over 30,000 follow-up appointments, so covering those appointments that actually are subsequent to the first outpatient appointment, along with the resultant surgical procedures or scans. We're hoping to deliver that across an 18-month period, but obviously the business case needs to go through the various levels of approval within the government before we can initiate that. But we are hopeful that we are able to finish the job on R&R. Second area I wanted to cover is just around ambulance. I always talk about ambulance response times and the fact that that we struggle to meet the category 1 times, but we always meet the category 2 to 5 times. That is the same situation this month. The category 1 mean response time is 8 minutes 29, which is under the 7 minutes target, but categories 2 to 5 we exceed. I just wanted to mention particularly in this section around Hear and Treat, which is a service that we implemented around 6 months ago, where we have a paramedic or a trained clinician within the control room triaging calls. So January, the service triaged 195 calls, which is around 20% of the call volume. 63 cases were downgraded, so the priority that the emergency service joint control room put onto the call was downgraded after clinical triage, but possibly more importantly, 34 calls were upgraded, so were increased in priority, so that the response time was quicker after they were triaged by a clinician, and 28 patients were directed to other services, and an ambulance wasn't conveyed. Next section I just wanted to cover was cancer waiting times. Again, we're continuing to see an improvement month on month around the 28-day faster diagnostic standard performance, which is currently at 69%. So we're expecting to reach the NHS England standard of 75% by April, which is the NHS England target. In terms of what actually means, our median waiting time for patients who are referred into the system and receiving the news, whether they've got cancer or not, was 19 days. In terms of just going, those were areas of improvement or areas of success. I just wanted to mention 3 areas of concern. So from an ED point of view, we can continue to see the impact of winter pressures within ED with a 4-hour target performance of 66%, which is just under the UK current performance of 70%. We have seen an improvement in some areas of performance in January. So we only had 2 days on Opal 4 in January compared to 4.5 days last January. 2 of those days were around the New Year period, where we had a unprecedented level of demand through ED, which thanks to some additional investment through the winter pressures plan, along with a more robust planning process, we managed to get through the couple of days of the first couple of days of January pretty much unscathed. And we also saw within ED a much lower admission rate for this January compared to last January. So last January we admitted 27% of patients that were presented at ED, whereas this January we only admitted 23.4. We're putting that down to predominantly increased staffing within ED, both from an emergency medicine point of view, emergency nursing point of view, and also we've bolstered the presence of consultant physicians in ED to make those early decisions to hopefully prevent admission and to formulate a different plan other than admission. Dental allocation dental allocation list. This is always a topic that attracts quite a bit of attention when the IPR is released, and this month is no exception. So we just under 5,000 patients waiting to be allocated an NHS dentist. That is increased 1,369 since April 2023. Our capacity for NHS dentistry remains unchanged. It's around 43,000 people have got an NHS dentist here on the Isle of Man. As I mentioned last time, we are continuing to have some challenges around how the dental contract works between Manx Care and our NHS dental contractors. We've agreed with the DHSC that we'll set up a working group to look at that dental contract. And the first meeting of that is this month in March to see whether there's anything that we can do between ourselves, the DHSC and the Attorney Generals, and also representatives from the dental contractors around how we can improve that contract make-up. Clearly, it's not a decision we can make on our own. It's very much linked to regulations, which are part of the DHSC's remit, and also what we can do in contract law, which is obviously the remit of the AGs. We do have a business case that is to be reviewed as part of the budget settlement that looks at how we fund dental contractors, and particularly us being able to provide a consistent level of payment for what dental contractors provide, because at the moment that varies in between dental contractors, and that's something that we will consider this month. And that's it. Thank you very much.
Teresa?
Yeah, sorry. I just wanted to come back on the cancer pathway work, Oliver, and I met the MDT coordinators a couple of weeks ago, and it's clear our systems and processes around tracking that cancer pathway have improved immensely. And it's really good to see that we're on an improving trajectory around the faster diagnostic standard. What I wanted to sort of understand was the work that's going on to maybe improve the administrative processes, because often that's where you can claw 2 to 3 to 4 days back outside of the clinical elements, and then also the work perhaps with primary care to make sure that actually the patient does understand they're being referred on a 2-week pathway and therefore does work with us in terms of appointment allocation. I just wondered whether you could say a few words on the improvements in both of those areas.
Well, I'll start with primary care, and maybe Dr. Ellis will want to jump in, but we have in the last month agreed to transfer the funding for the cancer GP lead over to the primary care network. It's been a slight anomaly that the cancer lead GP role has been part of Manx Care, not part of the primary care network, and which is at odds with the successful development of the network of clinical domain leads that we have. So with the appointment or the appointment of the current incumbent cancer GP lead into the medical director role at the hospice, that has provided us the opportunity to transfer that. And I know that the PCN, Dr. Ellis, Dr. Corkell and colleagues from our cancer team are going to be working on the job spec for that. So I don't know whether, Ollie, you want to say anything, but I think that personally will really help to develop the cancer, the development of pathways within primary care that then can link into the various pathways that we're developing within the hospital and then beyond into the Cancer Alliance.
Yes, I think it's a really positive step actually, and it ties in with the work that the primary care network has already been doing with Manx Care to improve that process from a governance point of view and from a patient point of view, from the point where they first seek help to getting into the hospital, to getting into the clinics. And so we've had a big focus on cancer recently, and there's a GP education session coming up which is very focused on cancer, and we've got a lot of the specialists coming to talk to the GPs about cancer, and we've been improving the quality. We've been improving the referral forms to align them with the most up-to-date guidance that and best practice, and also been talking to general practices about how to make sure we could do what's called safety netting, which is making sure that people aren't forgotten about, aren't missed, aren't caught between the cracks, because it's really important when there's that suspicion of cancer that every single patient knows what's going on, knows where they're being referred to and why, and knows what to do if they don't get a timely appointment.
Really helpful.
And Ollie's just touched on the other thing I was going to mention around the admin side of things, which is strengthening the referral forms and matching them against the Cheshire and Mersey Cancer Alliance referral forms that come in. One of the things that we've done actually as a result of an incident that was reported in the back end of 2023 is to map out the admin process of from the GP sending the referral form, going into the inbox, it being processed, triaged, booked in, because unlike most hospitals in the UK that have very definite cancer streams of clinics, the majority of our services, the cancer patients are mixed in with non-cancer referrals, and so having a kind of separate admin team to manage cancer appointments alongside isn't going to work here. So what we've done is to strengthen that process by mapping it all, identifying any issues where a referral may not necessarily go missing but end up being booked into the wrong clinic or booked into a clinic, say, a few months ahead. And so a lot of that has been done now. So
Thank you. That's true.
Really helpful. I can't believe I forgot to ask you because this. So I think the data is really helpful and really impressive, but I think it's the professional changes that sit behind the data that really is something we need to motor on. So 4 cataracts per session to 9 is a significant change in professional behaviours, if nothing else. So I'd like to know that as well as mining the data, we're reflecting this back to clinical teams to say, is this really what you intended? I think it's hugely important to remember that we measure what we can measure, which surgeons really means you count the numbers. It's easy. You've done 10 or you've done 11. But it's much more challenging when you come to outpatients and the chronic disease burden patients who have just as many needs. So I'm really keen to see that the next step of this in the outpatient diagnostic state is as successful, because that's a real challenge for everyone. And then just on your ED times, I think this is our front window in Nobles, and it really is something we need to think about. And I know there's an ED building proposal as well. And have we modelled what impact that will have when it's completed? So maybe not for answering now, but I'd like to see perhaps at some of the meetings where these are discussed a little bit of a deep dive into each section, Oliver, so that we really understand not just that we're on track, but how do we get to what this actually means and how do we ensure it's sustainable?
Yeah, and I think, certainly we're very focused on the 4-hour piece, but also those sort of Royal College guidelines around time in department. And I think, we're building that capacity around a same-day emergency care unit and clinical decisions, because those are the facilities that we haven't had in order to be able to move patients through the pathway. But that's all part of that UEC, Urgent Emergency Care Transformation Programme.
Thank you. Any other comments on Oliver? So I think we're now allowed a tea break. We're a little bit early, which is excellent. Tea's out. Where's tea? Out. Do we find ourselves a cup of tea?
I think there's some in the corridor.
Okay, excellent. So if we could come back at just sort of 27 minutes past, then we'll be ahead of the game. Is that all right? Yes. Elaine, you're looking at me, Elaine. Have I done something wrong? No. So 27 minutes past and we'll crack on. Thank you. Right, okay, well, we'll get started. Thank you for the second part of this. Pay negotiations update, Teresa.
Yes, just a very brief update following on from the update at the last board. I'm pleased to say that we have now reached a pay negotiation settlement with the MPTC NJC group of unions which largely represent our nurses and our allied health professionals and other healthcare workers and our social work colleagues. So that has been settled and signed. We settled, or the PSC pay settlement was achieved earlier last year. We remain in negotiation with our medical and dental colleagues.
Thank you. And I see just on a news flash that the BMA are recommending in England a settlement to consultants of 3.85% on top of 6%, something like that. So
Okay.
I presume that will filter through to us. It's graded against years of service, so it's a little bit more complex than that.
That's interesting to know. Certainly, for all unions, actually, sort of moving towards a 3-year settlement is important for all. So we have started those discussions with Treasury to be able to inform how we could reflect that in a 3-year offer. Certainly, a pay deal which is equal to or above inflation is certainly sought. You know, I think obviously we are finalising our budget setting, so being able to put an offer on the table very soon for our colleagues is an important priority for us. So we aim to do that in the next 2 to 3 weeks as we finalise budget setting.
That's helpful. Thank you. Any comments?
Chairman?
Yes, sorry, Nigel.
Yeah, I think I'm just thinking about geopolitical and geo-economic situations in that I detect from the news, and this will be no surprise to you, that the UK population is fed up with this Conservative government in the UK.
Really? Shock news.
Sorry, is this more humour from finance today?
Just say that this is a board in public. Can I just remind you?
Indeed, fed up. Nevertheless, I think there is a real likelihood of a change of direction in the UK, and historically that may well favour a reflation of the pay situation in healthcare and trust in the UK, and therefore we will be competing against the UK and a reflationary tendency in the UK in the next 18 months, I suspect. So therefore I think it behoves us to be mindful of that as we go forward in our planning. And I think it because we're not limited to recruiting from the adjacent island, but clearly we do, and clearly we are dependent upon it. And I think we need to be mindful of the fact that we are competitors in any pay negotiations and in any pay strategy going forward, particularly if it's for 3 years.
So I think that's really helpful, and it sort of plays into my thinking about we probably need, as a board, to have some horizon scanning as well about some of the wider issues around global issues that might affect Manx care. So thank you. We'll start thinking about how we might do that over the next few months. Any other comments? Miriam, workforce and culture update. Thank you.
Thank you, Chair. So much of the report I'll ask to be taken as read, but there are a few key issues that I'd like to pull out. The first is that the corporate people risks have not yet been fully scoped within the board as part of the board assurance framework. Some work has been going on behind the scenes around scoping those, and they will be coming to the People Committee and the Risk Management Committee and then onto the board later on in April. A review's also been undertaken into the shared services agreement with the OHR department so that we can be really clear on what we can expect from that shared services agreement and have proper systems in place to hold them to account, which are not currently in place. A paper has been prepared in conjunction with the Deputy Chief Information Officer and the Head of Information and Business Intelligence to understand a challenging issue we have in relation to people IT systems and the fact that our data is not kind of one version of the truth when it comes from different directions. So a paper has been prepared and will be going through the People Committee in March. A scheme of delegation and governance around people decision-making is also in development. That is envisaged that we'll be able to present that to the board in April. and that will feed into the wider governance review that you referred to earlier, Chair. The recruitment and retention strategy has been out for consultation and has been submitted to the Partnership Forum and the LNC in March and will come onto the board in April 24. The Manx Care induction is currently under review to try and pull that into some semblance of one organisation rather than having a varied approach depending on staff group. And finally, equality and inclusion. Sorry, finally, plus one. Equality and inclusion, we have now pulled together the draft of an equality and inclusion strategy, which will be reviewed during a workshop next week and will be going on to the People Committee after that. And then subsequently we'll be coming to the board with a number of actions around how we can improve inclusion across the whole organisation, which we will want to contribute to the integration agenda longer term. And finally, the Manx Care Staff Survey. That closed on the 31st of December. It has been challenging for the team who have been responsible for that to manage that data because they're not data analysts. With the support of our business intelligence colleagues, we now have that data analysed and a report will be going through to the People Committee and onto the board in April. Thank you.
Comments? Kate, then Katie.
Just a couple of quick ones from me. One,
Yes.
the scheme of delegation and governance. I don't know how far through, but that will be a key component, obviously, of the governance review. So it was just in terms of everyone being busy, whether there is a danger we do it twice.
Yes.
So it's whether perhaps offline you and I have a quick conversation about how we might.
Absolutely, Kate. So the idea was that I would draft something,
Okay.
feed into the review for us all to kind of knock about.
Oh, I misunderstood. When you said you were bringing it to the board in April, I thought that might be for approval, which obviously will. Is, yeah, okay. But if that's not the case.
At the time of writing, that was the case.
Okay.
Governance review was announced afterwards.
Fine.
So, yes,
And
apologies.
then, the other quick question was around the BMA survey, and I wonder if this is one from Marina, in terms of, I remember that being quite challenging before, and particularly the sort of implications for the barometer of care and all the rest of it. And I just wondered if your sense in terms of, we were hearing sort of medical engagement around finances is so much better, just wondered what your assessment might be. Fingers crossed, right, okay.
I'm very interested myself to see what that's going to produce. I know we've done the Manx Care survey, but I think it would be really good to compare with the BMA survey because that's what was done before.
Yeah.
And it would be the third time that we have it. And it would be interesting to see where there's improvement, where there's no change. And then we've got to start looking at why.
Yeah, okay.
And especially with what's gone on and with the paper that's come out from the Isle of Man Medical Society, my view is that there's still quite a lot of anxiety.
I see.
And that really needs to be understood and dissected and, and then we can know what to do. So I don't know, but I'm hoping there'll be improvement in terms of the work that has been done in Circle of Excellence groups, picking up issues on a timely basis and getting them resolved, trying to be very open and transparent. It's not always easy with complaints and with investigations, and really trying to protect the data so that it is looked at by the complaints officer and not jumping to conclusions beforehand. That comes with its own challenges. So I've really tried to drive that fairness, openness and transparency. But the question is it in my head or has it actually been driven down to the grassroots level?
Right.
And that's why the BMA survey is going to be very important and interesting to see what comes out of it.
Thanks, Marina.
Miriam, you want to come back?
Yeah,
before
just
Katie?
to add to what Marina is saying, we have also been doing a review of last year's action plan against that survey, which it will equally be going through to the People Committee. That's why we need it more often, Sarah, nowadays. And we'll be able to show which areas we have progressed on and which areas we haven't. As Marina's described, there's been a number of work streams that have been kind of pushed through that were taken from that agreed action plan from last year's survey. So whether or not this year's survey in terms of in terms of the outcomes when that lands, whether or not they reflect that work. You know, if they don't, then our action plan was wrong in the first place. So we will need to relook at that and scope that alongside wider organisational plans.
Thank you. Thank you.
Katie?
So my remark is around IT generally, and I've heard two things today which make me very pleased, but also I just want to sound a note of warning. Jackie said earlier around the fact that the business intelligence team was now sitting more closely in line with her finance team, which is great, and they're able to now to make financial and business decisions in lockstep. So that's brilliant. And you've just remarked about the fact that the HR function needs to understand its IT systems better, which is also great. So what I'm hearing is that the business groups and the end users are actively engaging in making sure that the systems are right for them, which is great. But can I remind everybody there is a D&I committee, and the D&I committee is there to understand the framework as it sits, so where we are in terms of our current systems, but also to help effect change. So if there's anything going on that is changing what we're doing, I would just expect it to come through D&I.
I think that's a really helpful steer, and we need to use our committees overall effectively. So thank you. Sarah?
Just a couple of things from me. It would be useful to understand the repeating of the workshop with the ED&I champions, and then you say you're repeating that with key stakeholders, who those key stakeholders are. In my experience, when it comes to champions of the staff networks, if an organisation does not give those staff protected times to do those roles, they won't get done. And I think we have said at this board many times the importance of establishing those groups, so it's brilliant that that is progressing. Yep. But I would really like the board to support protected time for those members of staff to undertake those roles, because I think, A, it signals that we really want those networks to be functioning, and B, I think it gives some time for those individuals to do a good job, rather than to see it as another burden on top of what they're already doing. I'm afraid this is a really personal point, and I apologise in advance for it, but I absolutely hate action plans and communications plans that say, you said, we did. I think it what's the word? Continues. Thank you. The parent-child relationship between an employer and employees. And I think if our staff have told us stuff, there may well be things that the management need to do, but there may well be things that staff need to do. So I just have a complete allergic reaction to a kind of communication that says, you told us this and we're going to fix it. Because actually, we're all in this together. And then finally, just the BMA survey, just a note of caution that we have no idea who completes that survey. We don't know if those staff are employed by us, were employed by us, are no longer employed by us, are retired. We have no idea. So whilst we must take it seriously, I think we just also need to be aware that we have been told by people who recognise people's voices, perhaps, that there may be people who do not work for us that are completing that. So just a note of caution around that.
So thank you. So I'm inherently cautious about the BMA survey for a number of reasons. One in which is that not every doctor is a member of the BMA. So I think you have to recognise that there are choices that doctors make. One of the real challenges in any staff survey is getting doctors to engage in a staff survey and getting doctors to consider themselves as employees of Manx Care and all of that cultural change. But it is worth pursuing. And there are a number of other survey tools out there that have been successfully used with different groups of doctors. And doctors, of course, are no more homogenous than any other staff group. And particularly in Manx Care, we have some very specific groups of doctors that we might want to think about differently. So I share some of the concerns about that. And I think the language around, the results will be used to measure. Well, I think the results will contribute to our understanding of things rather than that they're not our only measure. So I think we need to be careful about how we use other people's surveys that we have. I presume we have no input to the questions or anything, and we won't see that. I know because I've tried for years to get hold of the background details for these various surveys. So we started our own in HE because of that very reason. And then my other point goes to Sarah's point around the staff networks. Yes, time's important, but I also think some training and some support, because in some of the staff networks that I've been involved in, some issues, very serious issues of concern are raised by staff in those settings and to those individuals with an expectation that something will be done, and that can be really challenging. And they can range from quite significant mental health issues through to staff issues around employment. So I think it's really important that those networks are set up with the support around those leaders. And I think you're going to assure me that they are.
I am. That's what the workshop was. And in relation to your question, Sarah, the workshop was me personally providing that training so that I was assured that everybody was getting the same level, to anyone who was volunteering to potentially put themselves forward to be a staff network lead, and also to those people who had previously put themselves forward as ED&I champions, to give that benchmark level of training and to feed that through in terms of people committee and onto board at a later date.
Thank you. That's helpful. Charlie?
Complete change in tack. Sorry, Miriam.
All right.
I'm just, obviously we're aware that we're under shared services with OHR. Manx Care is kind of signalling a maturing of the organisation by undertaking these reviews. I think it's absolutely correct timing to do this. I really welcome it and thank you for the amount of effort. I'm just wondering if what we're doing here within Manx Care in reviewing all of these things, are there any dotted lines to OHR? Are there mirror image reviews that this is going to trigger? Is there a will for them to do the same and to also signal that there's a maturing of this relationship? Because we are absolutely required to continue the shared service, to work in concert with them. And if one part of the system is undertaking this level of reviews, which will be disruptive, because I imagine you'll be making some key recommendations of, some of them will be significant changes. What does that mean for our colleagues, comrades in OHR, and do you anticipate a triggering of reviews on that side of the partnership?
That last question is for them to decide, isn't it? But in relation to the work that I've been doing, being blunt, we don't have any people corporate resource aside from me within Manx Care.
Sure.
So all of these work streams are being delivered by people outside of the organisation.
Okay.
Workforce and Culture currently sits in the Transformation Directorate and currently sits underneath the Cabinet Office, which is over OHR. On the 1st of April, they will be moving over to the Department of Health. OHR themselves have also just completed the Grant Thornton review, where they reviewed their service across government. So what we're looking at is that very healthcare specific approach. But we only have so much control because all of these work streams sit outside, and with the best will in the world, I can't be a whole HR department on my own. However, we have an awful lot more input into the work of Workforce and Culture than we do of that in the pure OHR, because of the fact that it reports through to the Transformation Board, on which Teresa sits.
Teresa?
Yeah, I think the key here, Charlie, is to sort of make sure we keep that alignment, because government are progressing our public services, so they have recognised a number of employee and improvement work streams under the banner of our public services. We're linked into that as stakeholders, and I lead one of those work streams. But I think that's where we should make sure that the work we're doing is in complete alignment with our public services programme. I'd like to think we're leading the way in some of it, and we can piggyback onto wider government improvements with others.
Lovely, thank you.
Yeah, just to come back through you, Chair. Yeah, to add to that, an example of that where we are leading the way is in the equality and inclusion elements, because the Equality Act didn't come in Manx Care in the Isle of Man until 2016, and there have been key individuals in government that have approached me and said, we're really interested in the work that you're starting to do within Manx Care, and we would want to see that as a role model for other government departments. So there is some lead there going on.
Good.
That's good to hear.
Really helpful. Thank you. Any other comments or questions, Miriam? So thank you for all the work you're doing. There's a lot going on, I know. And I think you are a one-person HR band, actually, so congratulations. Right, so moving on to the final formal section. Director of Finance with the January management accounts, please.
Thank you very much. So, as usual, I will take the management accounts as read. So the main point to draw from the management accounts this month is that clearly there's been an adverse movement in the forecast, the operational spend forecast, of 1.6 million. That's largely due to the impact of the back pay element of the 22-23 pay award was 1.3 million higher than we'd anticipated. That has been partially mitigated, so our overall forecast movement has been 800k in the month. So that takes us potentially over the £30 million supplementary vote amount agreed. In response to that position, we've initiated a number of measures. So we've issued instructions across all of the organisation to immediately cease any non-essential spend, to defer any possible spend to next year that we can. We've conducted an in-depth review of all the current agency and bank placements that we have to see which ones we can tail off, end early or delay starting. And thank you very much to Oliver and his teams in terms of the work that's been done on there. We've assured ourselves around the rotas to make sure that they are not too heavy between now and the end of the year. And we've received some really good responses from all of the individual groups in terms of to that call to action. The actual impact on the numbers of that won't really be known until February's position ends or is reported. We are pursuing a number of potential upside opportunities that we think are likely to largely mitigate that overspend. But I think it's important to note that there still remains risk, and particularly we are now a little bit of the way through March, so we have 3 weeks of the financial year left to go, and by the time we know what's happened in February, the financial year will largely be finished. So we'll be looking with interest at what February's number tells us. But we're doing absolutely everything we can to bring it in underneath that 30 million. But I think it's important we recognise there still remains that risk if anything more unexpected comes to us or things don't quite translate in the way that we're hoping. There's limited capability for us to deal with it in the time left.
So I think, thank you, Jackie. It's a really pertinent point to make that the unexpected in terms of pay bills, which I think we're going to face next year as well. There's going to be a lot of pay settlements. And then to Nigel's earlier point about some of the global impact on our staffing and recruitment opportunities, potentially will reverse some of the very positive changes in agency spend. So I think what I think as a board we'd like to know is that we are sighted on this sort of risk a little bit earlier next year so that we can have those mitigation conversations mid-year, which is not a criticism of the finance team in any way at all, but I think we're better prepared for it this year because of the way in which we've faced the both mandate discussions and the way in which our budget's been set. So I think it's a challenging time for everyone. We are not alone in that in Manx Care. Any questions from anyone to Jackie?
If I may, there were just a couple of other points that I wanted to raise. So again, it's just drawing attention to the fact that the SIP performance continues to be ahead of target. So we reduced the target a number of months ago in response to delivery. That's now accelerated, so we've increased that again. So we are on target to deliver the 7.5 million of savings at the end of this year. It's also worth noting that when we look at the average run rates, so that's what it costs us every month to run our services, they are broadly continuing on that trajectory of a decrease. So our run rate in January, excluding the impact of that one-off piece, is probably about 500k less than what our run rate would have been back in August. So we are seeing consistent reductions in what it costs us on a monthly basis to run our services, and that's the impact in the bottom line of all of the other activity that we're talking about. And I think for next year, as I say, a lot of the savings around agency, we expect to have much more of an impact into next year as we go forward.
Helpful.
But it's also worth noting, just in terms of that wider context about the position that we find ourselves in, is it's worth mentioning that we began the year in a £9 million deficit position based on our end position last year, and we knew that there was about £9 million worth of pay pressure on us immediately. So that comes to £18 million, and we received 20 million of additional funding. So when we look at where the gap is and why that gap has arisen, we can see that the vast majority of that is related to just inflationary pressures. About 12 million of that is inflationary pressures. About another 11 or 12 million of that is purely to do with increases in pay awards. The remainder of that is largely due to, again, what we've talked about, some investments we've chosen to make in the system around safe staffing in midwifery, in ED, in nursing workforce, some of the stuff we've done around frailty, some of the transformation business cases that we now take the costs on. As an example, the cost of running the COVID vaccine service was previously funded from outside of Manx Care. That's £1 million. That's a cost that we've taken in. So we can clearly see why that 30 million has arisen and where it's coming from. But obviously that's something we now need to carry forward into next year. So when we start next, this is why we've got a piece of work to do, is because the position that we end in this year of spending close to 340 million is by and large our baseline position for next year.
Okay, thank you. I think that's very helpful, and I think more transparent we can be about the complexities of how our budget has emerged and is formed and is discussed and shaped for the following financial year, the more the public will have confidence in what we're trying to do. So I'm all for the explanation that you've given and making it as often as we need to with all of our stakeholders, including the public. So thank you. Any comments for Jackie on what's going to be a busy couple of weeks for you and your team? Thank you.
Not least the fact that as apart from landing the year end, we're also trying to allocate the budget for next year. It's very unusual in a finance team to be trying to do those two large pieces of work simultaneously.
Well, I think it's great that we have a budget confirmed before year end for the following year. That's a good positive step. But yes, we may resourcing of humans in these busy times of the year is something that perhaps we want to start thinking about as we head forward.
I've also just heard that from a broader Treasury perspective, the reporting timelines for year end have now been shortened considerably.
Okay.
So that brings quite a bit of pressure onto the finance teams in terms of managing those two competing priorities. So I'll just need to keep a close eye on that over the coming months.
So I think the context Manx Care and its budget is that there are wider areas of change within Treasury here and audit that are, everyone's affected by it. It's not just us, so that's helpful. Thank you. I have no items of any other business that have been given to me without prior agreement of the Chair. Marina, I usually don't take them at this last minute unless it's very urgent.
It's not urgent.
If you could perhaps discuss it with me afterwards, we can find a time for that. We have received some written questions from members of the public, which we will respond to with the timely manner that we always do. And then it says here on my agenda, board review, feedback on the meeting effectiveness, any new risks and assurances. So I think from the perspective of risks and assurances, year-end board meetings are always about finances. But I think it's very clear that the risk of that is around our credibility and our ability to negotiate honestly and openly in the future. So, and I think we've explored that very well. And I'm very grateful to the committees that have that focus, regardless of what the title of their committee might be. I think the meeting effectiveness is not for me to say. I think it's actually really for the public to say. But from my perspective, I welcome the quality of the papers and the clarity of our executive colleagues and their reporting. We were just discussing perhaps a change to the way in which we look at the integrated performance reports so that we can look more at trajectories and impact of trends and where we have made a decision to alter something rather than just simply the raw data. But those are all exciting opportunities for thinking differently. And thank you very much for your attendance. We'll now formally close the meeting.
Thank you.